Good afternoon. Thank you for inviting me. I'm a practicing family physician. I've specialized in medical informatics, and I manage the research institute in Maccabi for big data research. We cooperate with many academic institutes as well as, pharma companies and startups. And you know, Israel is this little dot there. It's very small. It's close, actually, here. It's 1.5, less than 2 hours flight. We are about 8.5 million patients, and our capital is Jerusalem. We speak mostly Hebrew and also Arabic. And we are known as the startup nation, and I think that's the flip of my talk. A lot of things that are happening in Israel are happening bottom up and not top down. We took most of the lectures that I've heard before, a top-down approach. And I'll show you a little bit. So we have a national health insurance. Everybody is insured. We pay about 5% of our income for health, and everybody is insured. We have 4 competing HMOs. We are the second largest HMOs. We are about a quarter of the population. And we spend only 7.5% of the GDP. If you compare it to the OECD, you see that it's less. This is Israel, and this is the OECD, and a lot less than in the US, of course. And we have very good outcomes. You can see that we are second in life expectancy, and we are very good in infant mortalities. So how do we do it? So in Maccabi, we are quarter. We have about more than 2 million members. We have less than 1% turnover a year. And we have a unique ID since Israel was founded. So I've heard this morning about Ireland creating a unique ID. We have unique ID for many, many years. And it's very important, and we have actually data from cradle to grave, and that's very important for research. So we are growing. We were 1% back then. Now we are about a quarter of the population. And if you want to see it compared to the US, we are the only members in the HMO research network of the US. You see, Israel is the only, Maccabi is the only one. And compared to the US, to the HMOs in the US in the network, we are third in size. So even though Israel is small, we are third in size the size of the HMO. And the retention rate of our patients is the largest. So we have longitudinal data, and we can learn from the data. We are computerized for many years. And as we all know, we are getting older. We don't see this nice triangle here anymore. We are a lot more adult patients. We are sicker, we are getting sicker even more than older. And we have a lot of comorbidities. You don't treat a patient with diabetes anymore. Each patient has a lot of comorbidities. So how do we do it? The researchers are shortage. We are sicker. We decided to do it with technology on the first place, on the second place, and on the third place. And we use it for many years. Everything in Maccabi is digital. E-lab, e-prescription, e-consultation, and it's for many years. We started in 1990 with volunteers. We started to reimburse the physicians. We started with the young ones who wanted to be with us. And in every version that we provided the electronic patient record, we provided a carrot, not only something else. And with teamwork, with our physicians, we created something that now we have virtual visit, not only e-prescription, but e-visit. Patient can ask questions, we can answer them. We sign it digitally, of course. We have virtual consultation between physicians and specialists. So I can consult with a hematologist without referring the patient, actually, because we found that the patient many times is the mailman. He just goes to the specialist, spend 2 months to get there. Then the specialist would tell him, don't talk, I want to write to your physician, and he gets back. So we do it virtually for many years, and it works very good. We have a very good rule engine in the system. So we alert the physician, and it's very easy to do. We can put a rule easily, and most of the rules that we put in the system, we put for the patients too, because, as we know, physicians are getting alert fatigue. Patients don't. They like to have alerts, and that's why we use the patient as partners for us. They see all the alerts, and they can tell us what to do many times. So we capture all the electronics, and on the top of the data, we build registries, and we have different kind of registries and sub-registries, diabetes, cardiovascular, cancer, etc. It's done electronically, and it's updated daily, but it has a closed loop to the physician. So each physician sees his list of registries, and he can say, this patient is not part of the registry, so we can improve the exclusion and inclusion criteria for the registry all the time. We also have all the cost. You can see here, this is the age of patients, and this is the total cost of this age. And you can see that, for example, pregnancy and infertility in Israel is more costly than diabetes, for example. You can see that hypertension is the most costly disease. So we have a lot of data. And we provide the physicians with the data. They see the data on the base of their clinic compared to the district, compared to all Maccabi. So, and we found out that we don't have to pay for performance. Physicians are very competitive. They don't want to be last. So you just show them the data, they will improve. The computers are very powerful. I'll show you one example. This was published in the JEMIA a few years ago. And you can see that when we select lab test, the most common lab tests are here. We just put an X on the lab test. All the rest are here on a list of a few hundred of lab tests. We have just changed the place. You know, we took the HbA1c, people didn't do it enough. We took occult blood test in stool. We put them up, and we took TSH, which thyroid function, everybody loves it. B12, everybody loves it. They are doing too much of those. We put them in. And in 3 months, we had 30% increase and decrease in the usage of this lab test. And the physician continued to do 8 clicks on average. So you have to use the computer really creatively, not only on the usual way that we do it. We have to think on new different approaches all the time. So I want to show you a little bit what we do about big data in the future, because I think it's the future. And when we talk about big data, is analyzing not only big volumes, but also variety of data, text, pictures, videos, etc., and do it in high velocity, just in time, and of course, bringing value to the organization. So I like to work with teams, and that's what I really like in big data. We have the domain expertise, which is me or my staff, the physicians, but we have mathematicians and computer scientists, and we work together in order to move from active disease here to healthy, low-risk, and at-risk patients, and I'll show you an example. Most of the research that we have done up until now is descriptive. It's about 85% of what we do. We say, this is happening, and maybe why it's happening. We do very little predictive, and even less prescriptive, which means we tell you what to do in this situation. Okay, so this is a real patient of mine from my clinic. He came in 2006, and he told me that he was diagnosed with colon cancer. And whenever a patient is diagnosed with advanced colon cancer, it's a failure of the system. You say, why should it happen? If we were alert enough, if we did enough work, we had to diagnose him before. So I started to ask him, do you have a family history of colon cancer? Did you have any complaints? Did you have blood in stool? No, he didn't have all of the above. So I went to the lab test, and I looked at his lab test. And in Israel, we love lab tests. By the way, we have in Maccabi 1 mega lab. All the lab test is shipped to 1 mega lab from all the country, and we get results same day. So I look at the lab test, and I see that you see he had in 2003 and 4, and another one in 2004 and 5, and it's normal, but you can see that the hemoglobin level here is dropping within the norm. You see, from 15.7 to 14. And we all know that when somebody has colon cancer, many times he bleeds and he has anemia. So if he had anemia, we were probably diagnosing it earlier and sending him to a colonoscopy. But when it was falling within the norm, I didn't pay attention to it. So I asked myself, could we diagnose him earlier? How often does it happen? So we took all the patients who were diagnosed with colon cancer and didn't have anemia and looked back. You see, here it's the controls, and here are colon cancer patients, and here they got the colon cancer. And you can see that about 3.5 years before, exactly like my patient, the hemoglobin level starts to fall within the norm. And it happens the same with females and males. So now that we published it, of course, but we asked now, this was descriptive, right, as we said. But can we predict, can we do something predictive? Can we take a CBC and say this patient was going to have colon cancer? That was the challenge. And you see that when we screen for patients, they all do lab tests, very little do FOBT. People don't like to play with stool. They'd better have a lab test. So our challenge was whether we can take a lab and predict colon cancer. And timing is everything, so I had a few mathematicians coming to my office telling me that they have done fortune in algo trading, in predicting stocks. And they said, can we do a project together? So I said, yes, I have a problem here. I have the CBC, I have the patient. Can we predict from here to here? And if we'll have it in the same specificity and sensitivity as FOBT, we can do it silently in the system. So we took age, gender, and CBC. By the way, we were sitting each Wednesday evening near my house in a coffee house at 8 o'clock in the evening for 2 years. And we developed a computerized model by taking 2/3 of the population, creating the model, then validating it on the other third here, and then we saw that it worked 1-to-1. So we asked ourselves, maybe it's only in Israel, we bought thin database from the England, and we saw that it worked 1-to-1. And what was interesting, that it's not the falling of the hemoglobin, it's the relationships between the MCV, MCH, and thrombocytes within the lab test itself, the CBC itself. So even if we had one lab test, we can predict most of the prediction. If we had a few lab tests, we could even predict more. We did a lot of work about it to see whether it diagnoses only in the proximal, not distal, but it's very good everywhere. And actually, what we did is implementing it in Maccabi, in the system. Because you know that when you have a family history of colon cancer, we refer you directly to colonoscopy. We don't do FOBT, because your risk is 2 to 6 times as a normal patient. We take 42 times as compared to the norm, as our threshold for alerting, and we alert the physician within the system. And we have many use cases that we can use the system. For example, we can use the system before the age of screening. Today, each physician, for example, I had last year a patient she was before 50, she was 48, she got colon cancer and she died because we didn't screen for her. We can take those patients before the age of 50 or above the age of 75 that we don't screen, and just screen them silently in the system. We can take also interval cancer. Today we do colonoscopy and we ask you to come again after 10 years. We can after 5 years, look at the system, maybe we have to do it earlier. But we decided to start with the non-participant. About a third of the patients don't screen for colon cancer. So automatically, when they do CBC, we give the physician result. This patient is positive for colon cancer. Even though it did only CBC, we have very good results. I show you preliminary results, but you can see compared to FOBT, which is the screening test, we have more malignancies and more polyp finding than today. And I can say that we have saved a few patients because they were not screened, and we found the cancer or the polyps without them knowing us that we screened for it. So it was published, and we wrote a patent about it. And this is a letter from a patient who is 80 years old, 80-something, 85. And he wrote, you know, I came to the gastroenterologist, and I told him I want to be screened for colon cancer. So I want to have colonoscopy. He said, you're too old. It's very expensive. So when he read in the newspaper about our patent, he told me, can you screen me with your system? And we screened for it, and we told him that he was okay. We use the CBC now to predict a few cancers, not only colon cancer. I won't talk about it, but we can predict lung cancer, gastric cancer, esophageal cancer, and we wrote patent on every one of them. So I think that data talks. We have to listen a lot more to the data. We can build a lot of predictions from the data and use it for the benefit of our patients. There are many challenges on the way. Huge amount of data, garbage in or garbage out. How do you share data? Privacy, security. We have shortage of data scientists, and we solve it by cooperating with the academia. I find it very beneficial. We have regulation issues, and also we have to change the way that we practice medicine, we, the physicians. I teach medical informatics and big data in the Tel Aviv University because I think the future is the students and the young ones, not the old ones. This is the lab that I told you, and since we have 1 mega lab, we are in a process of building a biobank now in Maccabi. Each patient that comes to the lab, we ask him whether he wants to be a part of the mega lab. We collect his blood, and I think having so much data, longitudinal data, with lab and big data technique, we can really do good translational research. It can't be done without collaboration, because that's why I think collaboration is the name of the game. That's why I'm here. Thank you very much.